Okay, I'd like to talk a little bit about radiation's late effects, and I'm going to try to make this interesting by telling us a little bit about Spongebob SquarePants as well. So, I want to contrast these first with the early effects of radiation exposure. So early effects are those biologic effects that occur relatively soon, as we've discussed, including acute radiation syndromes. There's substantial evidence that comes from numerous laboratory animal studies and data from observable irradiated human populations, like what we talked about with the Chernobyl firefighters and other populations. These are not common in diagnostic imaging. The one exception probably to that is exposures that are in cardiocath or with high dose rate fluoroscopy, and yet we do see some early effects of radiation in radiation therapy. Late effects are what predominate for diagnostic imaging, and there's two basic categories of late effects, which are late deterministic somatic effects, which we've said are determined by the dose, and late stochastic or probabilistic effects, which are like the random ones. And those are really the ones that we tend to worry about the most, is the probabilistic ones. And these are the result of radiation delivered over a long period of time. So the objectives for our discussion are we've just compared early and late effects of radiation exposure. Now we're going to compare all these risk models for various radiation exposure data. And finally, we'll discuss the epidemiology of late effects, including cancer, cataracts, and birth defects. And the major metaphor I want to work with as we're discussing this is this atomic bomb test that was performed at the Bikini Atoll in the 1950s. You can see the bomb was detonated just over the level of the water there in the ocean. And those little lines or specks there outside of the blast zone are like destroyer level naval boats. So this was following World War II, and these very large ships were disabled during the war, and so they moved all of these disabled battleships to the area around the Bikini Island, and then they did a series of tests in that area. They wound up exposing seamen to these nuclear bomb explosions, and some navalmen were affected by the exposures, and they also had test animals on the boats while they made these detonations. This is the reason why the swimsuit, the bikini, is where it gets its name from. Is that there was a French fashion designer who wanted to raise awareness about the Bikini Island tests, and it's also honestly where Spongebob SquarePants comes from, is just below the level of the ocean. We have Bikini Bottom, and so one of the easiest ways to think about epidemiology is the effects of those tests on the population of sea creatures beneath the level of the ocean where those bombs were detonated. Epidemiology can be thought of, according to our textbook, as the science that deals with incidence in distribution and control of disease in a population. And so these studies consist of observations and statistical analysis of data, such as the occurrence of disease within a group. And a large part of these studies include the risk of radiation-induced carcinoma. So we are going to use risk models to assess both the level of radiation exposure and then the level of risk or responses that could occur with any given level. So the way that we have learned to model this, at least in this classroom, is to consider these different radiation dose response curves. And so we have different theoretical curves that we can choose from. Curve 1 represents a hypothetical straight line, non-threshold curve. Curve 2 is a straight line threshold curve. And then the third one is a nonlinear threshold curve. And then B shows a little bit more clearly that there's a threshold here, after which we have a dose. And we've said that these are largely associated with acute or early effects of radiation exposure. And a lot of times this curve is used quite frequently in radiation therapy to depict the types of tumor response and cellular responses that occur from radiation therapy treatments. If a person received an actual acute exposure, like if a person had been there at Bikini Island when they detonated those bombs, the actual expression of that would look more like curve 2. There would be a threshold and then a straight line just straight up to some kind of point of overkill. So one of the ways to think about these threshold relationships is like Squidward. I think about Squidward being a pretty tried and true kind of guy. His normal facial expression is demonstrated here on the left. And so Squidward, if you were exposed to the radiation from these nuclear bombs, would just kind of make this face over and over and over again until, like we all know about Squidward, he hits a threshold and stuff tends to get pretty weird. So here is handsome Squidward as a pony for some reason. So with reference to ionizing radiation, threshold means that below a certain level of radiation dose, no biological effects are observed, and then all of a sudden we hit a threshold and stuff gets really weird, just like it does for Squidward. Versus non-threshold relationships, I think about being more like Spongebob. Spongebob's just kind of weird all the time. I don't know that I can think of what's normal for Spongebob. So non-threshold indicates that any radiation dose has the capability of producing biological effect. So what we are going to adopt in terms of thinking about these long-term radiation exposure effects is this linear non-threshold model, because any amount of dose creates some kind of weird effect. So that part of the reason we have adopted this model is because it is the most conservative model, because it assumes that there is no safe dose. Now this has been a point of some controversy, and so we're going to talk about why this would be controversial from a scientific point of view. When we think about risk, there's both absolute risk and relative risk models that we can think about. Absolute risk, I like these illustrations because they very clearly show this. Absolute risk means that there's a specific amount of additional risk that it can be added to whatever the normal spontaneous incidence of risk is. So for example, in the world of Spongebob, if there are talking squids at the bottom of the ocean beneath the Bikini Island test zone, then there were some amount of talking sponges beneath at Bikini Bottoms already, and Spongebob might represent an excess incidence of talking sponges beneath the ocean. Versus a relative risk model, it would say that there is, of course, some spontaneous incidence of talking sponges at the bottom of the ocean, but Spongebob might fall within that spontaneous incidence, or he might represent an excess incidence. And so the way to think about relative risk is that it could grow quite larger. The population could be bigger depending on a relative increase in incidence caused by radiation exposure. So why is this important? Well, perhaps most importantly, we have the leukemia occurrence in nuclear bomb survivors. So the incidence slowly declined into about 30 years after the initial peak in increase in leukemia. But what happened was we also saw a related increase in solid tumors. And so the questions of whether the related increase in solid cancers, this question has not yet been answered. But both of these risk models need to be employed in order to better understand how these incidences of increase relate to both the normal incidence of cancer or leukemia and any increase that would be related to radiation exposure. So, as can be assumed from this data, cancer is the number one, I'll say that again, the number one long-term health impact related to late effects of radiation exposure. So this data from Hiroshima indicates that the chance of contracting leukemia as a result of exposure to radiation is directly proportional to the amount of radiation you receive. And so the radiation-induced leukemia is assumed to follow a linear non-threshold dose-response relationship compared with leukemia in the normal population. So we're not completely certain whether that's an absolute risk or a relative risk, but at any rate, it is a real risk. With this, though, we also have demonstrated that the incidence of leukemia slowly declined in that population, and the incidence of solid tumors has escalated. In a related way, the information from Chernobyl is very, very difficult to look at, and it's one of the reasons why we're looking at animal populations like wolves and mice in the area of Chernobyl, because we had tremendous political upheaval in Ukraine. Following the power plant accident, a lot of people evacuated the area, so they are now living in other places, and they're very difficult to track down. Other people, like people who are refugees from Tajikistan and other Soviet bloc nations, have immigrated into the area of Chernobyl. And so what we lack with Chernobyl that we have with the nuclear bomb test survivors, again, what we lack is long-term monitoring, because we're talking about upwards of 135,000 evacuees to the area, and we still don't have accurate census data of how many people have moved back into the Chernobyl area. If you're interested in the complications of the Chernobyl area, highly recommend the book called Chernobyl Stories. It won the Nobel Prize for literature, and it's a very interesting book. It deals with a lot of the folklore and even like fairy tales that have come out of the Chernobyl area, and so I've really enjoyed it. Again, it's called Chernobyl Stories. So let's talk about these major types of late effects and what we have, and it's helpful to parse these out. We have two that we're going to call, well, actually three that we could call random or stochastic, and then one that is deterministic. And so the carcinogenesis, embryologic or birth defects, and nonspecific lifespan shortening are all definitely random in nature. The one that is deterministic or directly tied to dose is cataractogenesis. So let's talk first about carcinogenesis. As I've said, and I want to emphasize yet again, cancer is the most important late stochastic effect caused by exposure to ionizing radiation. It's a random occurrence. The severity of the disease is not dose-related. This box from our textbook illustrates some of the cases that have informed the research behind cancer, our understanding of radiation-induced cancer. And I want to illustrate some of the more significant cases here. Perhaps the most famous one is the radium watch-dial painters of the 1920s and 30s, and even before that. These women were working in factories in the New Jersey area. They were not informed of the risks related to using radium-based paint, and they were licking the paintbrushes and wetting the tips of the paintbrushes, and in the course of working, ingesting large amounts of radium, and numerous of them numerous of these people died of osteoporosis, so decalcification of the bone, osteogenic sarcomas or bone cancers, and other malignancies. Perhaps most pronounced malignancies in the area of the jaw, because this is an area where calcium is stored. So the big takeaway here is that radium, when ingested, is a very, very highly reactive substance. And of the 1,400 women that were working in this industry, 61 of them were diagnosed with cancers of the paranasal sinus and 21 with cancer of the mastoid air cells. So there was a marked increase in radiation doses to them. So one thing that's significant here is that this represents a CEDE, a CEDE, or a committed effective dose once they've ingested the radium, and your body's committed to that dose, because the radium behaves just like calcium. and so the body places it in the bones. Another example is the uranium miners, who were mostly Navajo. When uranium is mined, it's a cake or a powdery-like substance, and so they inhaled quite a bit of the powder in the course of working in the mines, and so by inhaling it, they received large radiation doses and had subsequent increases in lung cancer. But there's a lot of other cases. Patients, we used to use a material called thorotrast that had thorium in it as a contrast agent, and we treated patients, infants with enlarged thymus gland. We treated them with X-rays. Of course, again, going back to Bikini Island and the Marshall Islanders, they were inadvertently subjected to high levels of fallout during those atomic bomb tests that we were looking at. And then, of course, the material from the Japanese bomb survivors and patients who received postpartum mastitis treatments and the evacuees of Chernobyl. So all of these different populations represent relatively high dose exposures. So for us in diagnostic imaging, it is helpful to look at the Beer report from 1980 that talks about how the hereditary and stochastic effects related to low linear energy transfer radiation exposures like those used in X-ray, these appear to follow a linear quadratic threshold curve. And this term linear quadratic states to this line here at the bottom, which kind of has a little swoop to it. And I think this swoop is encouraging to some degree because you can see, and I think it speaks some to the radiation biology here as well, that the initial response may not be to very, very low doses of X-ray, like if you're in on a fluoro case or something like that. This initial response is not an immediate takeoff kind of high response. It is more of a gradual thing, and I think that gradual increase is in part because of the body's ability to repair. And so if we're talking about low LET radiation exposures over a long period of time with low doses, the body does probably have a chance to repair. And so in all likelihood, what is truly debatable is whether this linear non-threshold dose response model is actually supported by the facts that we have linear for us who are occupationally exposed. Probably in reality for us who are occupationally exposed, it's more linear quadratic, and that's encouraging because it means that we probably will not see all of the adverse effects that we would if it was a true linear model. But at the same time, we want to continue to maintain occupationally as technologists doses that are as low as reasonably achievable. So the risk estimates related to cancer suggest that there is no conclusive proof that there, with low-level ionizing radiation, low LET doses below 0.1 sievert, that there is any increase in risk for malignancy. So at high doses the risk is measurable. At low doses, particularly those below what we work at, which includes pretty much everyone in our classroom, this risk is not directly measurable in population studies. So what are the reasons for that? Why are we not able to measure the risk? Well, in all likelihood, the risk is overshadowed by other causes of cancer in human beings, like we've mentioned about exposure to chemicals or even sunshine and things like that. And the other probable reason would be that the risk is close to zero. All right, let's switch gears just a little bit and talk about a deterministic late effect. And this is the only deterministic late effect, is cataractogenesis. This is a very or fairly controversial subject, but a cataract is an occlusion in the lens of the eye. And so the thought is it's almost like if you can imagine a rock hitting a windshield. It might crack the windshield, it might not. But if you're driving behind a truck that's hauling a lot of gravel and there's a lot of rocks falling off the back of the off the back of the truck, the likelihood of getting a cracked windshield increases. The severity of the cracking of the windshield also relates to pretty much the number of rocks that then hit it. So the same is true with cataracts. It's like a crack in the lens. There's a very, very high probability that a single dose of 2 gray will induce the formation of cataracts, which can result in a partial or complete loss of vision. There is evidence of human radiation cataractogenesis. So in mice, we found that doses as low as 0.1 gray can initially or eventually lead into cataractogenesis. We don't have yet a definitive number for what the threshold is, but it is thought that this is the cataractogenesis follows a threshold, and so basically for diagnostic radiology and also for radiation therapy, we want to avoid radiation exposures to the lens of the eye. Occupational doses or to the sensitive area can reduce. Can be substantially reduced by wearing protective eyewear, and if patients are needing to have any radiation therapy treatment in the area of the eye, we're going to do everything we can to avoid the lens. Okay, before we talk about the embryotological effects, and so these are best thought of as somatic effects to the embryo, we need to understand this concept of dose doubling. Basically, doubling dose is the radiation dose that causes the number of spontaneous mutations occurring in a given generation to increase by 2 times their original number. We have arrived at a doubling dose number looking at the Japanese bomb data, and we've estimated that it has a mean value of 1.56 sievert. So if a population is exposed to 1.56 sievert, we see a doubling of the percentage of offsprings who are born with some form of mutation. I want to encourage you to very carefully read over the information in the reading packet on pages 18 and 19 when it talks about how the first trimester is the most crucial period with respect to adverse consequences from irradiation. So in that first trimester, we have pre-implantation, and if in pre-implantation is a period of kind of do or die, and so this is the embryo is a ball-like structure. It contains a lot of undifferentiated cells. If this is exposed to about anything from, I think our textbook says 0.05 to 15 gray, embryonic death will occur. There's no mutations that will happen because it will not implant. But then major organogenesis occurs approximately 10 days to 12 weeks after conception, and this is a really, really critical period. The abnormalities that occurred during this period can include growth inhibition, mental retardation, microencephaly, genital deformities, and sense organ damage. So this is very, very significant. So we might ask, what does that mean practically? Well, like our textbook indicates on page 19, we're talking about equivalent doses in excess of 200 millisieverts, which can result in either death or severe congenital abnormalities. So what examinations are we talking about Well, really nothing that we do in diagnostic imaging. I mean, probably the highest dose that we have is still like an eighth of that amount, and that would be the PET CT scan. And I don't think anyone's advocating that pregnant patients should have PET CT scans. Probably a close second would be a CT of the abdomen. That is a significant dose, as is fluoro of the abdomen. About 20 millisieverts of dose to the abdomen are delivered with the CT scan. But again, we're nowhere close to, that's still just a tenth of this amount of 200 millisieverts that can result in death or severe congenital abnormalities. So we do definitely want to avoid CT scanning abdomens on pregnant patients, particularly in that first trimester or during that period of major organogenesis. It does pose a risk. I don't want to de-emphasize that. It does pose a risk for the growth inhibition and mental retardation problems that have been seen in the data. But for us, as people who are occupationally exposed, we are well below this doubling dose amount of 1.5 sieverts. So there is an association of nonspecific lifespan shortening, and this is something that will probably continue to get worked out in the data. Perhaps one of the most interesting studies in this regard is the American Radiologic Technology, so the ART study that was started in 1982. It's currently still in progress. It's an extensive study of approximately 146,000 U.S. radiologic technologists, and it continues to look at long-term health outcomes related to their work. And the overall findings are that they did not practice a safety culture quite so much in the 1940s or prior to. So those technologists who worked prior to the year 1940 had some elevated risks for all sorts of health problems, but after the year 1950, we have seen some higher risks for leukemia, and as well as the risk of dying for breast cancer continues to be slightly higher than the average population. But on the whole, we can attribute this to a better safety, the practice of ALARA, shielding around X-ray tubes, and a number of other improvements in the way that we handle radiation. I think one thing, and it's just become a pretty hard and fast rule, that the probability of causation for excess fatal cancers follows a rule of roughly 5% per sievert. And so as long as we keep our doses below that sievert level, we probably are not significantly increasing our risk for cancer. So if you look at other things that are risky, like we mentioned earlier in the trimester, being an unmarried male, expected overall lifespan loss about 10 years. Frequent alcohol consumption limits your life by about a third of a year. And we're down here. If you're receiving 1 REM a year between these ages, you've probably reduced your lifespan by maybe 12 days. I've pretty much probably done that just with the amount of coffee that I drink. So, and thank you. And if you have questions, or if you want to debate whether or not Spongebob is caused by the Bikini Island tests, feel free to check out this video. You could just Google "nuclear bomb creates Spongebob?" and you should find a very informative video. Thanks.